right, good morning, everybody. I'm just going to spend a little bit of time talking to you in more detail about the test. Then I'm going to have Steve Rosenberg come up. He's going to speak to you and give you more details on kind of the reclassification data and how we can really use this test in practical terms. And then I'm going to end our section of this discussion talking to you about how I've been using this test in clinical practice. So, as you've just heard, assessing coronary artery disease and trying to diagnose somebody with symptoms that are concerning for coronary disease is quite challenging. This is not a small problem. As you know, there are millions of patients in the United States alone that come into our offices every day with chest discomfort and suspected coronary disease. Despite all of our years and all of our experience in assessing these patients, it's still very challenging trying to decide and try to sort out who has obstructive coronary disease as the cause of their symptoms compared to those who don't. One of the reasons that this is so complex is that there's a wide variability in individuals with symptoms. We know that women can have symptoms very different than men, but between different men and different women, they can have very different symptoms that are what we call anginal equivalents. In addition to that, the standard of care involving non-invasive assessment of coronary disease is highly variable. And what I mean by that is not the guidelines, but how we do it in our own communities. One area where you go, you may do standard treadmill stress testing in patients. Another area, you may get stress echo. Another area, you may do CT angiography, for example. So it's quite variable, and it can be very confusing and difficult to assess these patients.